Yeah. So cardiovascular physiology and cardiovascular anatomy. That's the task at hand. I thought it's better we start with the anatomy part, because after we are done with that, we can now focus on the physiology, which is more extensive as compared to anatomy. So when we say cardiovascular, we know what cardiovascular means. Cardio means the heart, vascular, the circulatory system, right? How blood moves from the heart all the way to your body and back to the heart. Yeah, we know that story. We started learning this in class 5. So it's nothing new. It's nothing new. So we'll start with the anatomy of the heart, then look at the few major blood vessels in the cardiovascular system. After that, we'll go directly to the physiology, which will take us a bit more time. Okay. So based on already we have a diagram. Yeah. Does someone want to just take us through the anatomy of the heart? Because now for the anatomy, it's just there's nothing much to be discussed. So does someone want to take us through the anatomy of the heart?
I can, but if I don't remember something, you can help me.
We'll all help you.
So the heart has 4 chambers, as you can see. The right and the left auricle, the right and the left ventricle. So we have the vena cava, which is a large vein that brings blood from different parts of the body. We have the superior and the inferior vena cava, bringing in blood into the heart.
Is it my internet? Jasmila, how much got disconnected?
Imagine I was buying bundles and like it.
I think it's her net.
KPLC. Wow. Okay.
No.
Pole, Jasmila. Welcome back.
Yeah, thank you. So deoxygenated blood from the right ventricle will go out to the lungs through the pulmonary artery, the one in blue. So that's the right side of the heart. Then on the other side of the heart, oxygenated blood will be received through the aorta, the very big, you can see it up there. Then through the aorta down to the right, the left auricle, and down to the left ventricle. And then, wait, does it enter through the aorta or the pulmonary veins? I think it comes from the pulmonary veins and then down to the
veins.
Atria.
Yeah.
Then the left ventricle, then out through the aorta to all the parts of the body. So yeah, that's the heart. In short, yeah.
Jasmila, she's told us about the how the heart works, right? From the entry of blood, from the right atrium, right ventricle, to the lungs, pulmonary veins, left atrium, left ventricle, aorta, then to the rest of the body, comes back, being deoxygenated through the vena cava. We have the inferior vena cava from the lower side and superior vena cava from the upper limbs and the brain, all coming, bringing down their blood to the heart. Then can someone mention about the valves of the heart? What's unique about the valves? What role do they play? And the heartbeat sound, does it have anything to do with the valves? We hear the ventricles contracting.
Were the valves the ones that prevent the backflow of blood in the heart?
Yeah.
Okay, that's their function.
Mhm.
I don't know what was unique about them though.
What's the other name given to this valve? It's this one, right atrioventricular valve and left atrioventricular. What's the other name that can be given to these valves?
Yeah.
The right
Mitral. Tricuspid na mitral ama?
Yeah, tricuspid iko kwa right ama left?
Right and then left ni mitral.
Yeah, great. How does the heart get its blood? I think that's the other part. Is the heart able to utilize the oxygenated blood that is in the left ventricle? Ama there are arteries that supply the heart with blood?
pardon?
Coronary artery ina supply to the heart itself.
Yeah, nice. Yeah, the heart, the blood supply to the heart is through the coronary arteries. The heart does not take oxygen from at the left ventricle, no, it's supplied by the coronary arteries. And the coronary arteries are usually there at the base of the aorta. As the aorta is leaving the heart, you get the coronary arteries there, exiting to go serve the heart muscles. Yeah. Is there anything else about the anatomy of the heart? We talked about.
You asked about the sounds of the heart.
The what?
You asked about the 4 sounds of the heart and how it relates with the valves. So I can remember the first sound, it's during the closure of arterioventricular valve, that's the tricuspid. The second sound, we said it's the closure of the mitral valve. And then the third sound, actually the first one is the lap that we hear with the thing, and then the second one is the dap voice that we hear, but the third one, it's linked with like the flow of blood to the ventricles. And then the fourth sound, is it arterial contraction or something? I don't remember about the fourth sound.
Okay. Dr. Karimi, do you want to take us again through the fourth sound?
Usually, the third and fourth sound are pathological sounds, except for sound 3, which is normal for children and athletes. As you see, there's a galloping, there's a like blood flowing into the ventricles with a lot of force, like overflowing, which is normal for an athlete or a child. But sound 4 is the atria is contracting against a stiffened ventricle. Means there is already something like a hypertrophy of the ventricle. So the atria is trying to push against a stiffened ventricle or an enlarged ventricle, giving us the sound 4. So automatically sound 4 is a pathological sound.
Yeah. Okay. And if I'm breaking, please tell me. I'm seeing that my internet connection is unstable. Yeah, so it's as Maria said, the third heart sound, that is S3, is whereby there is that passive filling of the left ventricle with blood, that ventricular gallop. But S4, it's the atria forcing blood into the ventricle. You know, it's the S4, the ventricle does not want any more blood, but the atria is forcing it. Yeah. And we usually see this even in diastolic heart failure that I know we'll cover in detail, but yeah. So yeah, someone in the chat box has talked about the sinoatrial node. You know, the sinoatrial node is a pacemaker, right? Now, what's the normal rhythm of the heart? Between what's that range that we consider normal?
For the SA node is 70 to 80.
Mm-hmm.
Yeah, and then
80. Yeah, it sets that pace.
And then for the AV node, it's 40 to 60.
Mm-hmm.
And then for the bundle of His is 20 to 40.
And what's the normal, like when you're just in the heartbeat? Below what will we say bradycardia? Above what will we say it's tachycardia?
Normal
It's
range
between
100.
Between what to 100?
60 to
100
60.
beats per minute.
Yeah, 60 to 100, yeah. So briefly, let's look at just the major arteries of the body. Then we'll essentially be done with this. Now,
Did you guys talk about the layers of the heart?
The layers of the heart. Hey, Hiral, tell us the layers of the heart, by the way, I forgot it.
So you have the endothelium, which is the innermost, then myocardium, which is now the muscular layer, and the outermost is the pericardium. Then, like, the whole heart is closed in a pericardial sac, which has now pericardial fluid and which just provides like lubrication for the heart.
Yeah, so the layers of the heart, the endocardium, myo, and then the epi. Then it's all in a pericardium. So so layers of the heart. Thank you, Hiral. Anything else we are forgetting about the heart? Okay, the good thing is if we won't cover it here, we'll see it when we're talking heart failure, when we're talking ischemic heart disease. I know we'll be revisiting the heart a lot. Yeah. So let's look at the aorta. We say the aorta is a main, this is where we pump oxygenated blood into, and this is the one that supplies the entire body, the aorta. So in the aorta, when blood is pumped into the aorta, here it is actually. You can see the coronary arteries here, just at the base of the aorta. As the aorta is leaving the heart, we have the right and the left coronary artery. These ones are the ones that will supply the heart. So in case of heart attack, myocardial infarction, angina pectoris, it's these coronary arteries that are filled up with that will be seen there's an emboli there. Yeah. Then so we have the ascending aorta, we have the aortic arch, then or arc, I don't know how you pronounce that. Then now these are the three the aorta here at the aortic arc. We have the right subclavian, the left subclavian. We have the brachiocephalic, which will supply the right side of your right hand, and also will break off to the right common carotid artery. We know the carotid artery is the one that is supplying the brain. Yeah. Then we have the left common carotid artery there as the second branch, and then the third branch we have the subclavian artery. So those are the three branches: the brachiocephalic, the left common carotid, and the left subclavian. Then from the brachiocephalic, we'll get our right carotid and our right subclavian. Then carotid, we know carotid goes to the brain. And that one, we'll see carotid more when we're talking about the brain. But subclavian, where does the subclavian go? Anyone with an idea?
I'm thinking around the clavicle area.
Yeah. Around the clavicle, it go all the way and supply the arm, right? The right arm and the left arm. Yeah. So here it is. We have just another diagram to help. We have the subclavian here, the right subclavian. You see, here it is. It's headed towards our upper limbs. The carotid, we know it's headed towards the brain, goes to form that circle of Willis, but we'll see that baadaye. But subclavian, we are seeing it goes to supply the upper limbs. Yeah. Again, let's see this. So from the subclavian, we get our axillary artery. Now this is at the armpit. You can see the humerus is there. Then from the axillary, we get the brachial artery, and then the radial and the ulnar artery. So the artery supplying the muscles here, the biceps, the triceps, will have the brachial artery. But in this ones, on the forearm, we have the ulnar and the radial. So that's how it forms. We've just followed the aorta. The aorta, we said 3 branches: brachiocephalic, the left common carotid, and the left subclavian. Now we follow the subclavian. We're doing from subclavian here, we get the axillary, hapo kwa around the armpit region. And then we get the brachial artery, which is supplying the upper arm, ulnar and radial supplying the lower arm. Then this bone is called the humerus. What are the names of these 2 bones? And the answer is kind of already there. The 2 bones of the lower arm. I don't know if lower is the right term. This cup bone and this cup bone. This bone that we are seeing the radial artery is over, and this bone that the ulnar artery is over.
See, they have the same name as the arteries, the radial and the ulnar. Ama?
Yeah. Yeah. So those are the arteries of the upper limb. Yeah, this is Yeah, these are the important ones. Okay. And then just for the lower limb, we know for the lower limb now we just see. Now the abdominal aorta, we've seen the abdominal aorta here. It's this one here, Ndoi, is it? Ndoi imeshuka. This one going down here. When it's in the thoracic area, we'll call it the thoracic aorta. When it's here, it's the abdominal aorta. And then now from the abdominal aorta, now here we'll get the iliac artery, which will supply that iliac area, the hip area, and then the femoral artery that will now supply the thighs, the femur, right? Femur here, femoral artery, and then the tibial artery, which will supply the lower part of the leg. Yeah. And then for the veins, it's the same veins going up. Yeah. So the major arteries, the femoral artery is a major artery, the tibial, the subclavian, axillary, brachial, radial, ulnar. Yeah. Yeah, I believe that's it for the major arteries of the circulatory system, unless someone has something to add on that. So next, we'll look at the anatomy of an artery. And we know the artery just has 3 layers. The thin layer, this is the tunica intima, the media is the thick one, and then the adventitia is the outer one. So on this point, who can give us a summary of atherosclerosis on this point? Because atherosclerosis, it starts here. Where does the fat go? Which type of fat? We always say LDL is the bad fat. How does LDL lead to atherosclerosis? Let me display an image. Yeah. Atherosclerosis, anyone? And we always sing in atherosclerosis. It causes heart attack.
So, LDL is I think the low lipid something. So it accumulates in the vascular wall. And then what I know is that atherosclerosis is basically the LDL accumulating in the vascular wall. So then it makes it a bit smaller, I think, like as shown in the picture. And so that will affect the flow of blood, because the artery will be narrowed because there's going to be that accumulation, and then it's going to form a plaque. And then I think the interruption in blood flow is what will lead to a heart attack.
The interruption in blood flow. Yeah. Okay. So where does the plaque form? Does it just form up? Let's go to the next image.
It forms on the.
It forms on the site of injury.
No,
the vascular wall.
That accumulation of cholesterol, does it accumulate inside the lumen or between some 2 layers? Where does it accumulate?
Between the layers, the subendothelium of the vascular wall.
Yeah, exactly, between the intima and the media. Yeah, between the intima and the media. Yeah. And then it accumulates. when it ruptures and platelets are exposed to it, platelets do what? They what is it called? They form that platelet plug and eventually form a clot. The clot will prevent blood flow. It will lead to no blood flow. Essentially, that person will now get a heart attack, they'll get a stroke. Yeah, that's why you'll tell them to exercise regularly so that they can prevent this buildup of cholesterol in this space. And in the same regard, who can explain why or how atherosclerosis can lead to hypertension? Based on this image, I think the answer is already there. Based on this image, how can
when the blood vessels become narrow, the pressure of the blood flowing tends to go up.
Yeah, exactly. It's that simple. You're having your tap, then we know we've played this game where you connect the pipe, then at the very end you block it with your finger, and the water comes out with a lot of pressure. Yeah, narrowing the radius of the lumen leads to increased resistance to blood flow, hence high blood pressure. Yeah, I'm seeing some about the platelets when this when there's buildup of this plaque, the plaque can be stable or unstable. So there are plaques that are stable, that it's not easy for them to rupture. And when I say rupture, I mean it breaking through the tunica intima. Okay, they are stable plaques, and even the likes of the statins, the atorvastatin, pravastatin, they stabilize these atherosclerotic plaques. But if it's not stable, the cholesterol is still building up, it eventually leads to rupture. Rupture means this fat, this cholesterol here will be exposed to the blood. Platelets, they'll do their job. When the tunica intima rupture, they go and accumulate to form a clot around the area. But as they form a clot, because this area is already narrow, that clot ends up filling this whole space. When it fills this whole space, blood supply to the organ that this vessel is supposed to be serving is impaired, leading to that ischemia, essentially leading to that heart attack, leading to stroke. Yeah. Okay, uko poa sasa ama, but we'll cover it further again when we're mentioning about ischemic heart disease. I'm sure we'll cover it again. Yeah. So that kind of summarizes what personally had prepared on anatomy. Unless someone has something to add, we can go directly to physiology. Nothing else. Okay. I remember the agreement is just that these diagrams are just here to help. Otherwise, you guys are the ones that are coming up with the answers. Or rather, yeah. So let's start with what we'll say the job of the heart is to pump blood to the body, right? So how does it do that? We know the heart is made up of muscles, right? And now those muscles, they have to contract so that the heart can pump blood. So someone mentioned about the sinuatrio, Hiral mentioned about the AV node, the bundle of his. Yeah, so now someone can explain how this sinuatrial node fires and how it eventually leads to contraction of the heart. Or you can explain even halfway till where you know, and then we can help you from there.
Okay, the sinuatrial node is the main pacemaker of the heart. So when it starts firing, it begins with inward currents that leads to depolarization. So the positive charge, like it increases the sodium influx into the cell and decreases the potassium efflux out of the cell. So that leads to depolarization of it, and then initiation of action potential. Yeah. And then continue from there. Nimesahau. Like there were three phases, I think. The first one is when depolarization is when the sodium enters into the cell. And then the repolarization one is like the rapid efflux of potassium out of the cell. That's when it starts moving do you remember the diagram that has the voltage in it that moves upwards until it reaches the plateau so that it can go to repolarization of it and again?
Yeah.
So the repolarization of it will come when calcium enters into the cell. I don't know if I'm making sense, but just explain in a good manner.
No, uko poa. Someone, Hiral.
Okay, so for the SA node, for this SA node and AV node, what happens is that these funny channels, sodium funny channels, they're always open, and they're always like pumping sodium into the cell. So when it starts, like an action potential is supposed to start, this sodium is pumped and it causes hyperpolarization. Then at a certain, I think, at -40 MV, that's when this L-type calcium channels open, and then it hyperpolarizes or is it depolarize? Yeah,
depolarize, yeah.
Yeah, depolarizes more, and then once it reaches like, there are T-type, the T-type calcium channels and the L-type. So the L-type opens at -40, and the T-type usually opens at -55. So it causes more depolarization. And then once it reaches like around over here, it's showing this 0 MV, or sometimes I think some textbooks show +40, but I'm not too sure about that.
You know, there's one for the action potential, and now there's one for specifically the heart. They are similar, but the millivolts are different.
Yeah. Okay, yeah, and then just once it has reached that maximum depolarization, these calcium channels will close, and potassium channels now open, where potassium leaves the cell and causes repolarization. So this calcium that has entered this SA node, or this these cells, now moves to the contractile cells of the heart through gap junctions. Now cause contraction. Now that's now the whole that action potential of the contractile cells, where there's those 4 phases. There's, I think, phase 0, 1, 2, 3, and 4.
Yeah, one of them was the relative refractory period. I think that's when that's phase 3, when there's no action potential that can be initiated. Like there's no any other signal that can come. Amma?
Yeah. It's usually from like phase 0 to phase 3, where that whole for the contractile cells right now, that it does not like no other action potential can occur.
Yeah. Hiral, do you have the textbook that guys was using? I can download from the drive. What's the name of it? And then I display. I think he's logged out.
I'm not sure, but just check. I think he sent on WhatsApp, I think yesterday. You found it?
No, it's in which group?
It's on BFAM. Oh, but anyway, gas is back.
Hey, what's up, Hira?
We were just looking for the textbook you were using, but you can just.
Okay, so you guys have, you've covered how depolarization occurs in the pacemaker cells.
Yes.
Great. So after depolarization, or assuming the depolarization has come from the sinuatrial node, what are the events that we're expecting to occur after depolarization? What contracts first? What contracts second?
So the atriums, like both of them contract together, and then once the signal moves down to the Purkinje fibers, then the ventricles, both the ventricles contract together.
Yeah. Now we can even now mention about the PQRST complex or the ECG. So about the ECG, let me just display the ECG here. Who can explain on the ECG, the PQRST? Looking for even here they are, that the P wave is atrial depolarization in it. I wanted a diagram so that we can see that P wave when we're talking P wave. There it is, I guess. Yeah, it is. Yeah, so the PQRST, what is happening at P, what is happening between P and the QRS complex, what is happening between S and T, and then what is happening at T.
Okay, so for the P wave, that's the first one where that's the arterial depolarization. Then you have the QRS complex, which is I think ventricular depolarization, and then the segment is now a complete depolarization of the ventricles, and then the T is repolarization of the ventricles. Then between T and P, the ventricles are like they're filling. That's when the filling takes place.
T and P?
T and P, between T and P. Yeah.
Oh.
So the ventricular filling takes place between, just kindly repeat.
The ventricular filling takes place between T and P.
Ventricular or atrial? Because see, the atria pumps blood into the ventricles. So we're expecting after depolarization of the atria, there is contraction, then the nini is filling in during that time. Just my thoughts.
Yeah, even I thought about that. Let me just confirm.
Yeah. Because the atria is the one that fills in just casually. The blood just fills in. Yeah, between okay, I've confirmed someone has sent a photo. Let's see. I'm even for the photo. The enlarged photo has the details. Let's do that. So P wave, we have atrial depolarization. Then the PR segment, we have the AV nodal delay. The QRS complex, as you say, that is where ventricular depolarization is, and also the atrial repolarization. Then the ST segment, this is when the ventricles are contracting and empty. Between the ST segment, the ventricles are contracting.
They're not contracting, they're relaxing. They're relaxing and feeling.
ST.
The TP.
No, I'm reading from here. ST.
Oh.
Yeah. ST, they are contracting and emptying. T wave, they are repolarizing. And then TP segment is when the ventricles are relaxing and feeling. So yeah, Hiral, you are right. Yeah, TP, between T and P is when the ventricles are relaxing and they are feeling. Yeah, so TP, the ventricles, they are relaxing after repolarization, and they are also filling up with blood. Then the P wave atrial, yeah. Then this whole process, it takes place in about 800 milliseconds. 800 milliseconds. Someone with something to add on the ECG? Go back. Anyone with something on ECG? It doesn't have to be physiology. It can be maybe a disease, something. So, okay, is asking which part is wider during tachycardia and which part is wider during bradycardia. I got in tachycardia, but this textbook, I think, has a diagram somewhere. Yeah, here it is. So in tachycardia, you're seeing they're all squeezed in pamoja hapa. Yeah, tachycardia, they are narrow, and then bradycardia, now they'll be wide. Bradycardia, now this is a complete heart block, but before a complete heart block is bradycardia, so they'll be wide. The distance between the QRS, because QRS is usually the shouting part. The distance between those waves will be wider. Yeah. And then what about heart attack? In heart attack, what do we notice? Anyone? Heart attack? Myocardial infarction? What's even the other term when we say STEMI? What does STEMI stand for?
That's the ST segment elevation myocardial.
Yeah, exactly. The ST segment elevation. Yeah. PPQ, RST, you can see there's this elevation here. Yeah, because this is the P. The T should be somewhere here, but there's this elevation. Yeah. So in heart attack, we see that ST elevation. Yeah. And what are the first line medications to be given in a heart attack?
I think not medication, but I think you consider that procedure. I think it's percutaneous something. I'm trying to remember the name.
Nitroglycerin, ama.
Yeah, even that.
Nitro, yeah, but the surgical. Let's say in this case, you're in the field before this person gets to the hospital.
Aspirin is the first line.
Yeah, aspirin to break down the clot. Yeah, the percutaneous coronary intervention, PCI.
Yes. But even this aspirin, like when somebody is like you can't do that procedure, you give them aspirin, those chewable aspirins.
Yeah. Because the issue with the heart attack, as we said, it's a clot. Adrenaline, not really, because we want to give vasodilators. So adrenaline, not really. It's usually morphine, oxygen, glycerin, and aspirin. The mnemonic is that MONA. Morphine for the pain. Remember, heart attack comes with pain. And also morphine has the advantage of also having some vasodilation activity. Oxygen, because there is ischemia, nitroglycerin, a vasodilator, and aspirin for aspirin to inhibit further clot buildup. What about for stroke? Who remembers the drug for stroke? That the patient had to be given within the first 3 hours or 4.5 hours if they met a certain criteria.
Aspirin is usually given after if the onset of symptoms is after 4.5 hours or something like that.
Yeah, true. But what if it's within?
Within was this thrombolytic alteplase, something like that.
Yeah, alteplase. Yeah, the TPA, also known TPA. Now we've talked about the depolarization part. The senior arterial node has done its work. Now we want the need to contract the muscles to contract so that we can pump blood. Even in muscle contraction, I'll even put a diagram. Who wants to take an yeah, here we are. Let me look for that. There's a good diagram for that. Yeah. Yeah, here it is. So our nerves have done their job. They've depolarized. This this is a nicotinic junction, but the events of contraction between skeletal and cardiac muscles are the same. So, who wants to take us through contraction of a muscle? Does a muscle contract? Muscle going down the TT. Anyone? Contraction of a muscle. What are the events? Hakuna mtu anataka kujaribu. The diagram is literally right there. You can read what is in the diagram and explain what you remember. I guess so. The action potential has arrived at the surface of the muscle, and it will travel down these TTBs. These TTBs are areas that deep down into the muscle, like they form this. It's like an entry into the muscle. Now, as the action potential moves down into or through the TTBs, it will trigger release of calcium, as you can see here. Calcium will be released from the sarcoplasmic reticulum. Once calcium is released from the sarcoplasmic reticulum, calcium goes and binds troponin. Calcium goes and binds troponin. What is the point number 3? Yeah, calcium will go and bind troponin. You can see troponin here. Calcium will go and bind troponin. This binding of calcium to troponin, it exposes causes the tropomyosin to move away from physically blocking the binding sites of actin. Usually is physically blocks, let's just say physically blocks that interaction between actin and myosin. But when calcium binds to troponin, it will cause the tropomyosin to stop that blockage. So once it has stopped that blockage, myosin and actin will now interact freely. You can see now myosin and actin, they've formed this thing called a cross bridge. And now this is where we need energy now. So far, we've just needed an action potential and calcium. Now, this is when we need energy. This binding between actin and myosin, what it will do is that a power stroke will be triggered whereby the myosin like pulls the actin. It pulls it, you can see, towards this direction. It pulls it like that. After it pulls it like that, or rather when it's pulling it like that, that is how contraction is happening, because it's pulling this actin like that. So after the power stroke, the cross bridge will detach and then it will attach now at a new site, pulling it again. Yeah, it will attach at a new site, pulling it again. But when the action potential stops, there's no more calcium available back to blocking that bridge between myosin and the actin, hence contraction will stop. Okay, contraction will stop. So far, we are good, hapo on contraction of our muscle. I guess silence means kopoa. So we can go back here, back to the heart. And just review now the contraction, the events in contraction of the heart. Here it is. It's just, again, it's nearly the same thing, just a slight difference. Action potential in the cardiac contractile cell will travel down the T tubules, and then that action potential down the T tubules will open some voltage gated calcium channels, right? It will open some gated, a few, there'll be entry of calcium from outside due to that voltage. Then that entry of calcium from outside will trigger the sarcoplasmic reticulum to release its calcium. And now that calcium, again, the story remains the same, binds to troponin, tropomyosin will change its shape. The cross bridge between actin and myosin is formed. The power stroke is performed and we'll have contraction. So the unique difference between skeletal and cardiac muscle contraction is that the current will travel down the T tubules in skeletal, but that current traveling down stimulates release of calcium from the sarcoplasmic reticulum. But in cardiac muscles, it will trigger a small entry or some entry of calcium from the ECF, and that entry leads to something called calcium-induced calcium release. That little calcium entering triggers calcium release from the sarcoplasmic reticulum, and then the story remains the same. Calcium, troponin, tropomyosin stops blocking, cross bridge formed. After cross bridge has been formed, we have the contraction. Yeah. So we already looked at the EKG, we talked about the PQRST, the mechanical events. Now here, the mechanical events of the cardiac cycle. You're talking about the systole and diastole. So here I'm sure you can't have you can't not have something to say. Yeah. So systole, diastole, what are they? What is usually happened during systole? What is happening during diastole? What are the Anyone now? Guys, Julissa is talking, so I know you know something about diastole and diastole. And I will unmute, say something. I'll try and unmute all these 3 months.
Okay, so systole and diastole. So systole is the contraction and emptying. Diastole is relaxation and filling. So I remember how I used to figure this was. So it has in relation with the breathing in and breathing out, Cindy. Is it? Guys, is it related to breathing in and breathing out? Like, is it something similar to that?
I don't know. Explain your story.
So, contraction and emptying. So I'm assuming by emptying it's when the heart is removing the deoxygenated blood and taking it to the lungs. Yeah. And then diastole is relaxation and filling. So that's when it gets the blood from the lungs. So contraction, usually there's gonna be excitation across the heart, which will it was polarization, then repolarization. So repolarization of the cardiac muscle. The artery and ventricles go through separate cycles of systole and diastole. Yeah.
Yeah.
Is it correct?
Yeah, that's correct.
Okay, so that is diastole. I don't know how to explain diastole well.
Okay, so Saru has explained diastole. So someone to explain now diastole.
So she explained diastolic, right? Amma? Guys.
Hello. She explained systolic. Amma, Saru, I felt like she explains systolic unless...
Yeah, I explained systolic where the heart contracts and pushes out the deoxygenated blood.
Okay, I think the diastolic, it's when the ventricles, I think.
Isn't it when they relax and now blood flows into the... See, we're talking about the ventricles. So when it contracts, that lab-dub sound. Not the
By
lab
the way,
contracting.
I think the diastolic is when the impulse reaches through the arterioles, and then like when the SA node reaches its threshold and it has already fired. I think the diastolic denotes the P wave, if I'm not wrong. It's the opposite.
Yeah, it is.
It's the opposite, right?
Okay, based on, let's work with based on what we know. Systolic is contraction and emptying, right? Then diastolic is relaxing and feeling.
And
And we are talking majorly when we are mentioning the word systolic, diastolic, systolic, we are majorly looking at the ventricles. Even the atria do undergo systolic and diastolic phases, but majorly we are concerned with the ventricles, right? So let's see, if the ventricles, we say ventricular depolarization is here at the QRS. We know after the ventricles have depolarized, the next thing they'll do is to fire, right? So if the next thing they do is to fire, that means immediately after the QRS, we'll be having contraction, right? We'll be having contraction. Hence, this is where we are having our ventricular systole. Then now after the muscles have contracted and repolarization is now occurring. Now the ventricles are relaxing because now they finish contracting. Now they are relaxing and feeling. So that relaxing and feeling is occurring just, you can say, here in between repolarization and the next depolarization of the ventricles. So between the T and the P here, the Q, it's literally what Hiral had said before, that in the between the T and the P segment, yeah, I hope tuko pamoja hadi hapo. Because yeah, this part it's important when we are going to things like hypertension, heart failure, and we'll just be mentioning these things without explaining. For the various volumes, the stroke volume, the end systolic volume, the end diastolic volume. Those ones you just have to go through them by yourself. This evening nakuja kuwa as much activeness as in the morning, so we'll skip through things because guys are not unmuted. Heart sound, we already talked about heart sounds. Valves. Yeah, now let's go to cardiac output. Who can say a thing about cardiac output? What's cardiac output? In what condition is cardiac output altered? What can we do about cardiac output? Anything you know about cardiac output?
So cardiac output, it's the volume of blood that will be pumped by each ventricle per minute. Yeah. So see, we've said the ventricle, they're the ones which do the most of the work in the heart. Yeah. So it depends on the heart rate and the stroke volume. So heart rate is the beats of the heart per minute, and the stroke volume is the volume of blood that is pumped per beat or stroke. So with the heart, it has certain beats per minute. I think the normal heartbeat per minute should be 72, if I'm not wrong. Am I correct? For a normal
60
person.
to 100 beats per minute.
To 100.
Yeah.
Okay, so so each volume of blood that is pumped out per each beat, they will bring a total to the cardiac output. Okay, so I think a person who has ventricular disease, that would affect their cardiac output. So if there's a defect in your ventricles, you probably have a lower output, and that will probably affect energy levels or something of the sort. So yeah, that's what I can say about cardiac output.
Yeah, nice. Then the formula for cardiac output is heart rate multiplied by the stroke volume. That means if you increase heart rate, you also increase cardiac output. If you increase stroke volume, you also increase in cardiac output, right? Now, in what condition do we notice markedly decreased cardiac output?
Can we say in ischemic heart failure?
Yeah, in heart failure, exactly. Heart failure is essentially the heart cannot keep up with the body's demands. Yeah, it means the cardiac output is not sufficient to match the body's needs. Yeah. So in heart failure, if anything, is the main condition where cardiac output is decreased. Yeah. And remember, cardiac output, it's a function of stroke volume multiplied by heart rate. Now, that is it about the heart. Now we can look at, we've said that the sinoatrial node fires by itself, but we know heart rate can increase, can decrease based on activities that one is performing, such as exercise, such as sleep, and all those things. And the parasympathetic nerve that supplies the heart is the vagus nerve, right? It primarily supplies the atrium, especially the sinoatrial node and the AV nodes, the vagus nerve. Yesterday, we were even talking about, is it yesterday or in the morning? Yeah, yesterday, about digoxin increasing the vagal tone and why we can use atropine to reverse the toxicity of digoxin to some extent. So we are not going to repeat that. Yeah. So we are seeing the vagus nerve. We know parasympathetic, rest and digest. Parasympathetic will cause bradycardia or decreased cardiac output. Whereas in sympathetic, they also supply the same areas, but they richly innervate the ventricle. So parasympathetic, we are seeing majorly it's in the atrium, whereas for sympathetic, majorly it's in the ventricles. So for parasympathetic, we know the culprit is always acetylcholine. For sympathetic, the culprit is norepinephrine. The receptors, it's the acetylcholine will have the muscarinic receptors. For norepinephrine, we have in the beta-1 receptor. Remember, beta-1, we say beta-1, we have one heart and two lungs. So beta-1 is found in the heart, beta-2 is found in the lungs. Yeah. So, but the beta-1 receptor, we said it's a G-stimulatory protein. Yeah, I hope by the time we took to cover G protein, when we say G stimulatory, you remember the entire pathway, right? So let's see the effect the parasympathetic and sympathetic have on heart activity. So sympathetic, let's start with sympathetic because it's the, this is adrenaline now. Adrenaline, we'll expect adrenaline to increase heart rate, right? So decrease the AV nodal delay. Remember the AV, once you decrease the AV nodal delay, you are also subsequently increasing heart rate because this is a delay. Then the ventricular conduction pathway, the sympathetic nervous system also increases that excitability. It increases the contractility of both the atria and the ventricles. Yeah. Then the other thing is that norepinephrine does promote secretion of adrenaline from the adrenal medulla, and also results in an increase in venous return, which increases the strength of cardiac contraction. Whereas now for parasympathetic is more of the chilled guy. It decreases heart rate, it increases the AV nodal delay, but it has no effect on that ventricular conduction pathway. It does decrease contractility of the atria, but not of the ventricles. Remember, the ventricles are everything. You don't want to mess up the ventricles. Yeah, adrenal medulla and in the veins, the parasympathetic system has no direct effect. Yeah. So essentially, it's just sympathetic will increase heart rate, it will increase contraction, it will increase excitability. Parasympathetic, the opposite is true. We know parasympathetic is the opposite of sympathetic. The diseases will be covered another time. So we already mentioned that the heart gets its blood supply from the coronary arteries, right? And we mentioned about atherosclerotic plaques. So we won't repeat that. The embolism, all of this. That is it. Unless someone has something to add on the physiology of the heart, I guess that is it from me. I really hoped we'd be more engaging, like we were in the morning, because we'd have covered more content, because the content can't be taught.